Mr. Anand Desai. He is a consultant surgeon from Birmingham, and he will talk about surgery in Desmoid.
Thank you, everyone, and thank you, Anita, for the invitation to come and talk. It's a difficult gig, really, talking and to really experts in the disease, people who've lived through it and cared for people with the disease. And I'm going to try and give you a flavour of really the role of surgery. There are some pictures here by the nature of the talk I'm giving that show surgery and can be fairly graphic. I hope they're not too disturbing, but I'll try and get through them anyway. And I am grateful to the patients who've given me permission to show them. So, surgery in desmoid fibromatosis. I'm a sarcoma surgeon, and sarcomas are tumours, cancers of the soft tissue. Fibromatosis comes into that differential of what the disease might be. So I work at the Royal Orthopaedic Hospital, and our catchment area is that big yellow bit in the middle. And the reason I say that to you is we see a lot of sarcomas from around the UK. And I also work at the Queen Elizabeth, which is a big new hospital. And really the reason I say that is that I'm lucky enough to work in a big team, as has been emphasised by the rest of the speakers. And there's a big group of surgeons who have an interest in sarcomas and related diseases. And it's very important, particularly in fibromatosis, I hope to demonstrate. So the basic principles of surgery in sarcoma are, you may wonder why I'm going on about it, but I'll come to that in a moment. Surgery is the only curative treatment for disease, for sarcoma, that is. And the basic principles of surgery are to remove the whole tumour, not drop any within the field, and to take a healthy cuff of tissue around the tumour. And in the extremity, this is what it means. So you can either stay very close to it, you can take a bit more, or you can take the whole of the affected area. And the reason for that is the reason for that is this. This is a paper from Milan, and it shows that if you leave a little bit of the tumour inside, it's more likely to come back. That's common sense, really. That's not the case in fibromatosis. This is quite a busy slide, but essentially that column shows you that even if you leave a little bit of fibromatosis inside, it may or may not come back. And if you have taken it all out, it still could come back. It's a really odd disease. So it's not true to say that if you take a big margin, fibromatosis won't necessarily come back, and vice versa. And the reason for this, and we've touched on this, is this slide over here shows that it's not a sort of golf ball type thing with a nice smooth edge. It's got tentacles that reach all the way out, all the way around, and it's star-shaped, which makes it very difficult for a surgeon to know where it starts and ends. So until 2000, a senior colleague of mine who's just retired would just remove all of these. So they would just get cut out. And we would go absolutely wild. You would go really wide because you knew that fibromatosis had a sort of star-shaped appearance. And we would go much wider even than in a cancerous situation, the situation of a sarcoma. But they still recurred, 40% or more. Very morbid operations. There's a lot of side effects from taking away such a lot of tissue, a sort of slightly misguided attempt to remove it. And the patients are young and often female. And double butt, there was a possibility, as we've heard, of them going away by themselves. We know there's high post-op recurrence, and we know it's benign disease at the end of the day, although you can argue about definition of benign in this context. So there was this move in the sort of 2000s to 2010s to avoid surgery. So I came up with this algorithm with a surgeon when I was a fellow in Paris, and this is quite complicated, but essentially there are 3 different bits to it, and this is 2011. And it starts with Barty-Proven desmoid. And if it's not in the head and neck, or we'll come to this in the discussion later, then you basically watch and wait. If it starts to progress, or it's in the head and neck, you give chemotherapy, or if you're a lady, you get some hormones and then you get chemotherapy. If it continues to progress, then all the way down here on the 3rd algorithm finally comes in surgery, whereas that was previously right at the top. And you've seen this. This is an adaptation of the work I did with Dr. Bonvolo, and the surgery's sort of down here somewhere, not up here. So here, I'm just going to present some cases, so I'll warn you when the gory bits are coming up. This is actually a good news story. So this is 2011 when I started as a consultant, and I tried to change really what was happening in the department of just removing all of these. So this is the first lady I treated. Recently had a baby, had noticed a lump prior to the baby, and then they got bigger during the pregnancy. She had a biopsy. That's March 2011. This is an MRI scan, and as we were talking about, this is her six-pack, and this is quite a big desmoid. There it is a few months later. There it is 6 months later, and then about a year, and then, finally, this is it here. And so I discharged her 3 or 4 years later, flushed with success that I'd done nothing and avoided surgery. And so spontaneous regression is a feature, particularly in young women with sort of pregnancy-related desmoids. And we see actually something like 20% of cases can regress, 50% will be stable, and hopefully a small minority requires surgery. So the next lady, actually it's a bit later than 2000, I've got the date slightly wrong, but she, as I said, with that in my mind, I had another 2 years postpartum, similar age lady, lump in the abdominal wall, painful from the outset, but with the fact that I'd been winning with a number of other patients, I encouraged her to watch and wait. So this is it here, and then unfortunately it's got a bit bigger, and then, oh dear, it's got really quite big. So it's very difficult to persuade someone to carry on watching and waiting after sort of 18 months of steadily watching it get bigger. And of course got my senior colleague breathing down my neck saying, take it out. So I did an operation in September of 2013. The actual tumour was only about 6 centimetres. I moved 15 centimetres of abdominal wall, and despite that, despite that, the margin was positive. So a 6 centimetre tumour, a dinner-shaped, or dinner plate-sized excision of the abdominal wall, and I got a positive margin. And unfortunately, there's the recurrence. So you can see this is her six-pack on the right, and on the left, it's missing because it's been removed and replaced with a synthetic material, and then there's a recurrence. So the lesson was that you can't get away with watch and wait every time, and yet the surgery is also a little bit thankless. So really, that's the point. It's really deciding who would benefit. So that's the abdominal wall. Within the abdomen, things are a little bit more it's a bit more difficult, and you're often pushed into surgery a little bit more when the disease is in the abdomen. This is a case of a 27-year-old man admitted to the local hospital with acute abdominal pain. Was taken to theatre with a lump and had the colon on the right side removed with the lump as an emergency. Turned out to be a desmoid in hindsight, and because of the way the emergent surgery was carried out, there's no criticism of the surgeon. The margins, that is the edge, it was not completely removed, not possible to remove it completely. Despite that, so this is the tumour, an enormous thing, and I'd say our colleague did extremely well to get this out in an emergency situation. And then 5 years later, it has not recurred. So despite the fact some was clearly left behind, it has not recurred. Again, a real oddity. This is a patient of my own, an 18-year-old man who, again, presented with an abdominal mass that he'd felt himself, increasingly symptomatic, and the biopsies were equivocal, as they can be in fibromatosis. And it's difficult to see, but that's it there, quite a big lump here in the right side of his abdomen. So I did a very similar operation, but as an elective, as a planned procedure, that is taken the right colon out with a little bit of the duodenum, quite an extensive operation for a young man, and a 7 centimetre desmoid with clear margins. The whole thing was removed according to the pathologist. So this is his first post-op scan, which looks great, and that's where I've joined up the bowel over here. And then unfortunately, 18 months later, there's a recurrence. And I can't tell you why this has recurred, despite the fact it has apparently all been removed. As I say, I'm just emphasising the curiosity really of this disease. And he's subsequently had post-operative radiotherapy. This is a situation where surgery doesn't really have a part to play, and he's had radiotherapy. So this is a young lady who I treated last year with familial adenomatous polyposis coli, which you probably all understand is a condition that predisposes to bowel cancer and desmoids in certain cases. She'd had a colectomy, which is the removal of the bowel to remove or reduce the chances of colon cancer in the future, and ileostomy in 2016. About a year later, had noticed a lump in her abdominal wall. She was treated with imatinib, which is one of the drugs that Palmer's talked about, but there was rapid progression. Now, there are some pictures here of her condition. Now, this is an ileostomy, and this is the disease trying to come through the abdominal wall. Look at the date there, that's the 24th of June. This is just 3 weeks later, and it's progressing before your eyes. It's a very, very aggressive disease. So this is a situation where you have to operate as an emergency, really, where there's no watch and wait. all other treatments have failed. So we had to cancel the patient on the following list and bring her in and carry on and do the surgery. This is the preoperative CT scan saying a huge abdominal wall tumour. That's her ileostomy there, big abdominal wall tumour. So just some pictures of the surgery coming up. So this is the joint procedure with plastic surgery.